Good afternoon, everyone. Welcome to our webinar on opioid use disorder and the anesthesiologist, what you need to know to impact the escalating crisis. I am Gene Viscusi. I have a bit of introductory information and introduction to our faculty today. So, first, I want to acknowledge that there has been no commercial support for this session. And if you missed the 2024 IARS meeting, those sessions are available on demand. You can find those at the IARS website on this slide. And also, the upcoming IARS meeting is in Honolulu at the gorgeous Hilton Hawaiian Village. Also, your speakers today will be available for questions and comments and continuing discussion on the IARS members community. There are also several other webinars coming up that may interest you. One is the IMRA, an insider's guide to successful IARS grant submissions. That is on January 23rd. And on April 8th, the Women Impact of Women in Anesthesiology, Advancing Leadership. That is, as I said, on April 8th. Also, at the end of this session, we will take your questions. There is a Q&A button in the Zoom taskbar. And once we finish our presentations, I will go through those and we will answer as many as we can in our allotted time. So now I'd like to introduce our faculty. As I said, I'm Gene Viscusi. I'm the Vice Chair of Pain Medicine at Thomas Jefferson University in Philadelphia, an ASRA past president, worked heavily in the drug development arena for the last 30 years, and also had a flourishing career as a professional musician while doing all of this. So it's been a fun run. Following me, Lynn Kohan will speak on the management of opioid use disorder in the perioperative setting. Lynn is a professor of anesthesiology at the University of Virginia in Charlottesville, where she is the division chief of chronic pain medicine and the program chair. She is on the ASRA Pain Medicine Board of Directors, also the AAPM Board of Directors, serves as president of the Specialty Program Directors, and is the immediate past president of the Pain Program Directors. She also serves as editor on numerous journals. Oscar de Leon is a professor of anesthesiology and pain medicine at the School of Medicine and Biomedical Science at the University of Buffalo, where he's also chief of pain medicine and professor of oncology at Roswell Park. Oscar has served on many committees for ASA and ASRA. He is, like myself, a past president, and he has the distinction of being named as one of top doctors in the U.S., best doctors in the U.S., top 100 docs in Buffalo over the past 15 years. So with that, I would like to begin our session, and remember to hold your questions. So I will provide a brief overview of opioid use disorder implications for anesthesiologists. I do have financial relationships with several entities. However, none of their products will be discussed or mentioned or have particular relevance to my presentation. I will not be discussing investigational or off-label use of any pharmaceuticals or devices. So to frame our webinar, I would ask why, as an anesthesiologist, is opioid use disorder my problem? Why should I care? And then as an anesthesiologist, may I prescribe buprenorphine? Do I need special training to treat or manage opioid disorder? And if we embrace this as anesthesiologists, how many lives are we likely to save? Which is, I guess, the real point of why we should embrace this area. So, just very quickly, the U.S. overdose deaths have exceeded 111,000. For the last 3 years, the number of deaths has exceeded 100,000 people. And to put that in some perspective, that's roughly 300 people a day dying of this unfortunate circumstance. It's like a commercial jetliner crashing every day. So surprisingly, 75% of overdose deaths occur in the home. The majority of deaths are related to these synthetic illegal fentanyl analogs. They are cheap and easy to produce, unlike heroin that requires a crop and growing a material. So these illegal fentanyl analogs are either processed as for use for IV or snorting, or as these look-alike tablets, which typically contains 7 to 10 times a lethal dose of fentanyl. Commonly, these are now mixed with xylazine or medetomidine that intensifies the high, but also intensifies the severity of withdrawal. There's also this fourth wave described in overdoses of fentanyl with stimulants, which has increased tenfold in the last decade. I would make a case that we should think about having naloxone, carrying it, keeping it in our homes, and making sure that our patients with opioid use disorder have access to naloxone when they leave the hospital. Behind all of this is the fact that you may not cure addiction, but you have a chance at another day. You can't treat someone who has died of an overdose. And some of my colleagues get a bit frustrated with the numbers of times these patients come into the hospital in and out of recovery. But the reality is it takes about 8 attempts on average for patients to enter recovery and stay in recovery. So it's important that we encourage and provide every opportunity to continue life. Remember that overdoses can occur on the first experimentation, which can happen in your own home. It could be your child, a neighbor's child, maybe even a grandmother who is misusing or not using drugs correctly. We're still working out the availability of naloxone, but it is thankfully an over-the-counter drug, so anyone can get this drug in any pharmacy now. Typically, the costs are $20 to $40 with insurance, maybe $50 without it. But most states have giveaway programs, and it is fairly easy to get free naloxone. I would point out it's not a panacea. It's not the answer, but it's a chance for another day. And it is an area where we as anesthesiologists and perioperative physicians can make a huge impact in saving lives. So what is our role? First, reducing reliance on opioids for analgesia, which is part and parcel of the perioperative process. That means using multimodal techniques wherever possible, and that we should feel very comfortable managing these patients throughout the perioperative process, meaning how do we manage our intraoperative anesthetics, maximizing non-opioids, ketamine infusions, regional anesthetics, and then postoperatively, how do we manage these patients if they are in recovery or if they are still using illegal drugs. We are in that unique position as perioperative physicians that we can encourage the continuation or initiation of buprenorphine in the perioperative process. It's relatively easy to do, and there are a few things in medicine that can save as many lives as introducing buprenorphine management. So why should we limit opioid use? This is the CDC data that shows as little as 5 days of a prescription opioid are linked to persistent use. So it's something that we are experts at these drugs to avoid opioids, and we should make every effort to minimize minimize opioids and promote non-opioid use in the perioperative period. So a few quick words on the pharmacology of buprenorphine. It is described as a partial mu agonist, but that does not mean partial analgesia. It is a potent analgesic. Buprenorphine is notably a kappa and delta antagonist. That is extremely important because the depression, euphoria, dysphoria of opioids is linked to kappa agonism. And by having this kappa antagonist effect, it reduces those effects that may drive the continuation of opioids. It reduces opioid withdrawal and craving in the opioid use disorder setting. It's a highly competitive ligand for the mu receptor, meaning it will displace other opioids. So if you give buprenorphine to someone who has substantially blocked receptors with, say, illegal opioids, you can precipitate withdrawal, which is very uncomfortable. However, if you slowly dose with an antagonist, just as you may do with naloxone, you can reverse some of the effects without causing a complete withdrawal. Once bound, buprenorphine can impair the binding of other mu agonists, but there are almost always some receptors unbound and available for either other opioids or increasing buprenorphine doses if needed. But remember, buprenorphine is a potent analgesic. There are minimal respiratory effects and, in general, reduced opioid side effects. There is this class of opioids now referred to as bias ligands that spare or reduce the beta-arrestin pathway effects. And it is quite likely that buprenorphine falls into that category. So the big question that we will all need to address is, my patient is on buprenorphine preoperatively. What do I do? Do I discontinue it so I can give other opioids, or do I continue it and risk that those receptors are occupied? And does that mean poor analgesia? We have, thankfully, some really good evidence that says we should continue buprenorphine. The McIntyre paper is one of the best earlier references that shows whether you continue or discontinue buprenorphine or methadone, the quality of analgesia is about the same. And these authors highly recommend continuing buprenorphine or methadone throughout the perioperative process. A more recent paper by Dr. Hitt, retrospective review of large data from the Veterans Database, showed that continuation of buprenorphine was not associated with higher pain intensity ratings or higher opioid requirements, and again, supports that we should just continue this. Another consideration is, if you discontinue, you expose patients to the opioids and their effects that led to their addiction. And it's shown that there's about a 50% or greater chance of relapse or death. And that increased risk of overdose death is likely related to changes in tolerance when you've discontinued. So it's highly recommended to continue buprenorphine. So buprenorphine is an excellent analgesic. It's important when dealing with patients in recovery that you set expectations and you involve your patient in the decision to continue buprenorphine. And of course, that you will be very attentive to withdrawal should it occur. Discuss the multimodal approaches, which would be the oral or parenteral choices, acetaminophen, non-steroidals, gabapentinoids. Ketamine is extremely useful in the intra and postoperative period. I find that clonidine is very helpful. Regional or epidural techniques are the real foundation of analgesia when you have patients who are profoundly tolerant to opioids. It may be helpful with buprenorphine or methadone to divide their regular doses. And it's critically important to remember that warm handoff at the end of care back to whomever may be prescribing these drugs on an outpatient basis. So the real hook that I want to present is that when you have a patient with opioid use disorder, looking at their risk of death, the highest period of risk is in the first 28 days following discharge. So if we can think about those causes, the need to facilitate treatment, get them on buprenorphine in that first month, it's extremely important. Your chance of saving lives is greatest if you can get them into treatment, even for that short period of time. Now, I'm sure Dr. Kohan will talk about this expert review. It was a multi-society expert panel that had endorsement of 5 societies that made specific recommendations about the continuation of buprenorphine or the benefits of initiating buprenorphine in the perioperative period. I'll leave those details to Lynn. But very briefly, the manner that we do this that works quite well is first discuss it with the patient. The patient has to be agreeable with treatment. Make sure that they understand that we will do everything that we can to keep them from experiencing withdrawal. We hold their opioids, their PCA, for maybe an hour or two, or wait till the end of the oral opioid dose cycle. And then we titrate buprenorphine 2 milligrams every 2 hours as needed for pain. And typically patients will use somewhere between 8 and 16 milligrams a day. I found with this approach, I have not caused withdrawal, and that patients have essentially equivalent analgesia, and then can be quickly converted to buprenorphine alone prior to discharge. It's useful to have adjunct analgesics, multimodal analgesia, particularly ketamine and clonidine. There is also a microinduction technique that our addiction medicine people like to use. I'm not going to go into great detail with this, except to say it has some benefit in patients who are extremely reluctant to start buprenorphine or on very high doses of opioids. It's a very slow process, starting with several days of microgram dosing. But it is useful in some patients, although there's no universally accepted microinduction protocol. And to my knowledge, there are no guidelines or societies that have endorsed this approach. So as we wrap this up, I would say buprenorphine is life-saving. The numbers needed to treat to prevent 1 death from overdose is questionable based on the study. The one I like is that says the NNT is 3. So imagine, what can I do in medicine? What therapies can I initiate that will save 1 out of 3 patients? It's very rare that we can have that high an impact. And then to wrap it up, we will be dealing with the opioid crisis for many, many years. We're seeing this disturbing expansion of the illegal opioid supply, mostly fentanyl, but some very dangerous, novel other opioids combined with stimulants, benzodiazepines, and these veterinary drugs like xylazine and medetomidine. There is, as I said, this significant incidence of death in the first month following discharge. Buprenorphine and naloxone are life-saving, and we should be comfortable with the use and recommending this. And I would end with saying that we as anesthesiologists and perioperative physicians are in a key position to save lives by both managing buprenorphine and encouraging the use of naloxone and its availability. And with that, I am going to turn this over to Lynn, who will talk about the perioperative processes. Thank you.
Thank you. Sorry about that. Apologize for technical issues. I don't know why it reverted again, but thank you. The next part, we're going to talk a little bit again about buprenorphine, but then we're also going to talk about methadone and naloxone as well. And so essentially kind of concentrating on some of the pharmacological effects of the different agonists and antagonists, and then kind of how we apply those principles when we're taking care of patients in the perioperative setting. So just kind of some background information. So for patients who are opioid naive or undergoing surgery, about 6% of them who get an opioid exposure during the surgical period could develop long-term opioid use. And so that's different than opioid use disorder, but can end up on chronic opioids chronically. Unhealthy use, about 40% of patients that are presenting for elective surgery can present with some kind of unhealthy substance use prior to surgery, and about 20% of those may be using illicit drugs. In terms of the prevalence of OUD, it's an estimated about 6.7 million people in the United States. And approximately 12% of hospitalized patients might have a substance use disorder. So as you can see, this is prevalent, and therefore we as anesthesiologists would be encountering these patients potentially frequently within the perioperative period, which is why this is an important topic. So how is substance use disorder diagnosed? Just in brief, the APA criteria for OUD involves kind of different categories. And so it's important to understand that the pharmacological criteria for patients who are on those long-term opioid therapy, that in and of itself does not, lead to the diagnosis, but they need to have signs of impaired control. So kind of meaning I didn't mean to use so much. I tried to stop, but I restarted every time. Everything I do kind of seems to be around getting this drug. Social impairment. They continue to use despite the fact they know that using the drug of choice has resulted in problems at work. They've lost family members, they've lost friends. Again, they've stopped doing hobbies, things that they enjoy, because more of their time is spent thinking about the drug. Risky use. In addition, they also keep doing things that are risky or dangerous, and they know are risky or dangerous, but they're unable to prevent themselves from doing so. And there's also a criteria, a classification for opioid use disorder. So depending on how many of these criteria you meet, mild 2 to 3, moderate 4 to 5, and up to 6 or more would be diagnosed as severe opioid use disorder. So what does this mean, in the perioperative period? Well, for one thing, there's actually treatment, very successful treatment for patients on who have opioid use disorder. And so using medications, and we're going to talk about the 3 FDA-approved medications for opioid use disorder, can be an effective treatment. There are going to be times, it's a chronic disease, so it's important to understand that patients return to use, and that's okay, and you just have to keep helping them each time. But it's important to try to get them into treatment because treatment reduces the spread of infectious disease and reduces mortality, risk of overdose, and just really increases the likelihood of successful treatment. So what are the 3 FDA-approved medications? So we have methadone, buprenorphine, and naltrexone. And so it's important to understand that they all have different characteristics. So methadone, as you know, is a full mu agonist at the mu receptor. Talked about buprenorphine being the partial agonist and naltrexone being an antagonist. And so because of these properties, when we're thinking about them in the perioperative period, we're going to have to apply different principles when we're taking care of these patients or anyone with opioid use disorder. It's also important to understand just some differences. Methadone, when it's used for opioid use disorder, can only be provided by a licensed outpatient treatment program. Buprenorphine now can be applied and prescribed in any medical setting. You no longer need an X waiver to prescribe buprenorphine. And naltrexone can also be prescribed in any medical setting. Some other nuances that methadone has a lower risk for diversion. Buprenorphine can be a high risk for diversion. It does actually have really high street value financially because patients sometimes, or people will go on buprenorphine in between being able to get other full mu agonists that they might be using illicitly. And then it's important to understand that naltrexone, not being an opioid, has lower risk of diversion, and that buprenorphine and naltrexone, because they can be prescribed in any medical setting, have a lower stigma associated with them, because unfortunately with methadone, people need to go to the methadone clinic, and this could be stigmatizing for patients. So getting into a little bit more of the individual drugs. So methadone, as I mentioned, is a full mu agonist. It does activate delta and kappa receptors. So unlike buprenorphine, you're going to potentially get more of that euphoria and associated respiratory depression. It is an NMDA receptor antagonist, which can sometimes help with some neuropathic pain. It is important to understand that it can prevent the reuptake of serotonin and norepinephrine. So if other drugs, that can interfere with other drugs that the people might be on. Those have a long half-life. It's also important to understand that it is highly bound to the alpha-1 acid glycoprotein. So this can be important when you're initiating other drugs that might displace it. It's also important to understand that while its half-life is long, its analgesic half-life, the period of time that it actually provides analgesia for, is much shorter. And that's why we can optimize that by sometimes dividing the dosing. It comes in oral tablets in solution and also in the IV form, but it also can increase QTC prolongation. And so what to do for patients in the preoperative period who may be on methadone is to verify their home dose with the outpatient, the licensed treatment program. It's important to understand that methadone, when it's prescribed, in that way for opioid use disorder, does not show up on the PMP. It only will show up on the PMP when it's prescribed for analgesia. Communicate with the prescriber and review the EKG as part of the anesthetic plan, because they may have that prolonged QTC. On the day of surgery, it's important to understand and confirm when the last dose was taken. If it was not taken, you can administer the dose. If they're NPO and they're not allowed to take any, oral tablets, you can consider giving a half of the oral dose as in the IV formulation. It is important to understand that patients on methadone could have opioid tolerance and hyperalgesia. They may require higher intra-op doses of opioids, but it's really more important, rather than to just keep exposing them to more and more opioids, is to maximize those non-opioid multimodal treatments that Dr. Viscusi was mentioning. And so in addition, then for the post-op period, you want to continue the home dose unless for some reason the dose reduction is indicated, which would not, would be pretty rare to suddenly reduce the dose for a patient who is being treated for opioid use disorder. In some cases, if they were also using it for combined analgesia, there might be some there, but I wouldn't recommend just reducing it on your own. I would talk to the prescribing physician clinic. Always monitoring for mental status changes, respiratory depression, hemodynamic changes. Again, if you need to try to optimize analgesia within the post-op period, because it has that shorter half-life, you can consider dividing it in different doses. The patient is MPO, you can give IV kind of a third to half of the oral dose every 6 to 8 hours. And then it's always important if you're to give short-acting opioids on top of that to provide an opioid taper. You want to get them back to what they were prior to their hospitalization and provide naloxone. Dr. Viscusi mentioned the importance of naloxone. Buprenorphine, we talked about a lot of this. It is a Schedule III medication. The important points, again, to highlight is that it is an agonist at the opioid receptor like 1, which can be also contributing to its effective analgesic properties. Dr. Viscusi mentioned the beta-arrestin pathways, which is good because it leads to potential for less respiratory depression and some of the other side effects like constipation and tolerance. He mentioned, and you can see graphically, that buprenorphine does bind tightly to the opioid receptor. It's really only sufentanil kind of above it, so it can displace other medications. And so that's important to understand. It's also important to understand that it is actually a relatively safer medication for patients with hepatic and renal insufficiency, unless these are really severe. And so that is something that is good. In terms of when you're thinking about different formulations, so buprenorphine is approved for both opioid use disorder as well as for analgesia. And so if you see patients on microgram dosing, those are generally for analgesic purposes. So the transdermal patch and the buccal film, Butrans and Belbuca, while milligram doses can be used in pain, that's off-label, but you see patients on milligram dosing, that is usually for the treatment of opioid use disorder. We talked about kind of to continue or to stop, right? And this debate is, well, these patients come in on this buprenorphine and there's no way I'm ever going to be able to treat their pain, right? They're just going to be impossible to treat. But as Dr. Viscusi mentioned, discontinuing really places them at risk of return to use, overdose, risk, and death. And it's also been shown that the continuing buprenorphine actually does not in and of itself result in poorer analgesia. And so how to actually treat these patients. So in the preoperative period, you want to verify the home dose with the outpatient prescriber, and it's really recommended in most cases to continue that home dose. He mentioned the paper, the multi-society guidelines paper, where you really looked at, can we really continue buprenorphine? There have been prior studies. He mentioned kind of the receptor binding, and as you get into higher doses, yes, your receptors will be filling up with buprenorphine, leaving less room for other opioids. But at the same time, buprenorphine in and of itself is a very effective analgesic. It was not initially manufactured as a treatment for opioid use disorder. It was manufactured as a potent analgesic. And you can see that in studies in the past, they looked at comparing buprenorphine and morphine in the postoperative period, and both have shown that to be efficacious. And in some cases, buprenorphine actually even outperformed morphine. We talked about the study already where they looked at the patients who, patients who actually discontinued from their methadone or buprenorphine actually used larger amounts of IV PCA opioids than patients who continued. And so buprenorphine and methadone, they can both provide effective analgesia. So in the perioperative period, you want to maximize your multimodal treatments, ketamine, lidocaine infusions, regional techniques. If you need to use opioids with high binding efficacy, such as fentanyl. Postoperatively, you want to continue buprenorphine, consider dividing the dose, and if necessary and if available, consider IV buprenorphine. Upon discharge, communicate with the outpatient prescriber. Again, it's really important if you added any opioids that you want to provide a taper back to the original dosing. And again, be very important to provide naloxone. So what about naltrexone? So this is a bit different because it's a antagonist, a weak kappa and delta antagonist. There's different formulations. So perioperatively, you want to communicate again with addiction medicine specialists. If you can, delay elective surgery for 28 days for patients who are particularly on the long-acting formulation. Stop oral 48 to 72 hours preoperatively. They're on the long-acting injection. You could always consider stopping that and converting them to the oral formulation, so at least they're not uncovered for a period of time, and then kind of discontinuing the naltrexone the 48 to 72 hours preoperatively. In some cases, if they are really at high risk, it might be better to just continue and try to do an opioid-free anesthetic. So if you discontinue, can use short-acting full mu agonists, but you do have to remember that their receptors have been antagonized, and so you might need to go low. They might be more susceptible, so starting low and titrate to effect. It's kind of this variable situation depending on how long they might be off. There are some patients who might be more susceptible, but there are other patients who might be less susceptible. So just being really cautious about how you're prescribing your opioids, and then in addition, maximizing your multimodal treatment. And then in the post-op period, again, we talked about the unpredictable opioid sensitivity and of course, using multimodal treatments. Upon discharge, it's when you're thinking about if a patient came off, do I reinitiate this in the hospital? The FDA, typically says to reinitiate 7 to 10 days after the last opioid dose. There might be chances, though, in the post-op surgical patients to try like an oral challenge, a small dose of naltrexone. You don't necessarily want to leave them uncovered for a long period of time after they leave the hospital. So you can try giving a small amount and seeing if they're experiencing withdrawal, but then if they don't, then they can reinitiate their long-acting injectable naltrexone. And the similar themes of communicating with the prescriber and providing naloxone. So essentially, in summary, for buprenorphine and methadone, you generally want to continue those medications and using multimodal treatments, and always providing naloxone, providing tapers, and communication. Naltrexone is a bit trickier if you need to discontinue. Depending on if it's the extended release naltrexone, you can bridge them, and the oral being discontinued 48 to 72 hours before surgery. So what about the patient who's not in treatment? And this Dr. Viscusi kind of talked about might be a prime time. They might be actually ready to undergo treatment because they're in the hospital. They're understanding that perhaps their disease has been impacting them, and hopefully they're in a non-judgmental care team environment. There has been a lot of evidence that buprenorphine can be safely initiated in hospitalized patients, and that doing so actually results in longer periods of recovery. Dr. Viscusi kind of mentioned there's microdosing techniques, a little bit harder in the hospital perioperative situation because it just takes a little bit longer, but you can, as you mentioned, can start in patients who are on IV PCA or oral medication. You can give low doses. He mentioned, stopping the IV PCA 1 to 2 hours prior, and then starting with low doses of buprenorphine. And if they're on oral post-operative full mu agonist, kind of instead of giving them their next oxycodone at the kind of 4-hour mark, kind of initiating that buprenorphine and these low doses at that time. So in summary, opioid use disorder is a chronic but treatable disease. Patients should generally be maintained on their medication throughout the perioperative period. Naltrexone needs special consideration using multimodal analgesia, close collaboration. But it is, we as anesthesiologists can initiate buprenorphine in the perioperative period to help treat an opioid use disorder and effectively still control pain.
Okay. Thank you, Oscar, and thank you, Lynn. So we're we're pretty much up against our deadline here, but if we have maybe just a couple of minutes here, we can explore the handful of questions that we got. I can kind of run through these and summarize some quickly. One was just the acknowledgement that it's not only our patients, but also our colleagues who may be suffering with opioid use disorder. And, I've certainly seen it among colleagues. I've seen overdose deaths. I've seen suicides related to drugs. So it is an extremely important consideration, and I think it's something that we need to be aware. Look for problems with our colleagues. Anytime you see aberrant behavior, it's important that we act on it, because the sad result is death. Let me see. There was a question about, let me see, questions seem to get jumbled a bit, so I'm missing some of them. One was a question about an experimental drug, atipamezole, which is a specific alpha-2 antagonist, and whether it would have utility. Since this is CME, I can't comment on unapproved drugs, except to say, yeah, I mean, I think it needs to be studied. It's a veterinary drug, but that it may have some utility in humans. And we should certainly look forward to seeing results, but I don't know specifically, nor can I comment whether it would really make a difference. I don't know if either of you have any comments or experience with atipamezole.
No experience.
None.
If
So,
I agree with that.
if
yeah.
I can work with lofexidine and clonidine, I'm happy.
Yes. The question is, in the overdose setting, would a specific antagonist rescue, or, whether naloxone plus atipamezole might be a good rescue agent? And the answer is, I don't know. We haven't studied it, but it certainly is a question worth
Well,
pursuing.
this is why nalmefene came to the market, right?
Yes.
So that is an added value because of the half-life. So I would say, get your hands on that medication and try to use it, because
Yeah.
it really has a longer half-life, 4 to 6 hours. So, that will avoid the problems with short effects from drugs.
Great. There was another question about when patients have been initiated with buprenorphine, sometimes aggressively up to 24 milligrams, would it be better to leave some of the receptors unoccupied so that you could mix a full mu agonist in the postoperative period? And would that produce better analgesia than just buprenorphine? Um, uh, I'd be curious what either of your thoughts or comments might be.
I think the most important thing is to get them to the dose that's going to prevent to reduce their cravings. And so whatever dose is needed to reduce that risk of return to use is a focus. And you got to remember, buprenorphine is a highly effective analgesic. So I'm not sure there's necessarily a reason to hold back at a lower dose if they're still experiencing symptoms, cravings, because you're concerned about analgesia, and you're concerned about the need to put in the other full mu agonists. Gene or Oscar, I don't know your thoughts.
I have had patients like that, Gene, and I drew on my experience with sufentanil research early in my career. Sufentanil has the highest intrinsic efficacy of all opioids. So if you are at a 24 milligram a day dose, you're likely to have 90 to 95% of the receptors occupied. So you need a opioid with high intrinsic efficacy. You may get away with hydromorphone, 1 milligram Q6 minutes, but sufentanil will do the job. And needless to say, you already have implemented ketamine, lidocaine infusions, you have ibuprofen or ketorolac. acetaminophen, lidocaine patches, etc. So you threw everything you had. But IV PCA sufentanil, 7 to 14 micrograms an hour basal infusion with boluses of 10 micrograms Q10 minutes will save the day for you. And the problem is that not a lot of hospitals carry sufentanil anymore. So if you are seeing a lot of these patients, talk to your pharmacist, P&T committee, and explain, what's going on so that they can get a small stash for you so that it can be utilized when needed.
Yeah, I mean, I think my personal experience that's supported by the current literature is that whatever you do, you're going to get about equivalent analgesia on these very opioid tolerant patients. But buprenorphine is safer, and it eliminates some of the euphoria and the effects that drive addiction. So my preference is just to keep them on buprenorphine, and as Oscar said, capitalize on these potent non-opioid agents.
Yeah, use both. Yeah.
Yeah.
Don't back down on the dose, but add the sufentanil.
Yeah. Yeah. Now there's a question. I'm not sure I understand it completely, but I think it's asking whether buprenorphine or methadone would have utility in the perioperative period for patients who are on naltrexone. Lynn, that would sort of follow your presentation.
Yeah, I maybe there's different components to it. I think maybe, it's a little bit more complicated in a patient who's on naltrexone, right? Because buprenorphine and methadone, I don't know if you're asking if they're already on naltrexone and they stayed on their naltrexone, or if they've come off their naltrexone and instead of exposing them to full mu agonists, you're going to expose them to another type of MOUD. But in general, so that there is more analysis of prior studies looking at buprenorphine even for an acute for acute pain as an acute pain analgesic, which shows that it can be effective. In that period, if the patients, if you're going to try to reinitiate the naltrexone, though, you have to remember that buprenorphine and methadone have a longer half-life, and so that might you might need to take that into account if you're thinking about when to reinitiate the naltrexone. And so I would, definitely talk to the naltrexone prescriber and see kind of where that patient is in the recovery, because there's a lot of nuances. Again, I'm not entirely sure which scenario you kind of mean, and so it's hard to kind of give a definitive answer.
Mm-hmm.
I don't know if you guys have thoughts.
Yeah, I think that the participant is thinking of a situation where the patient is on naloxone and has the need for emergency surgery, right? Or comes to the ER with trauma. And then you're faced with this patient who had a major surgery who needs analgesic treatment. And I would say that under those circumstances, I will reach for sufentanil first and, get over the hump. Needless to say, the multimodal therapy. And then contact as soon as possible. Keep in mind, communication is critical in this population. Mm-hmm. Contact the individual, prescribe the naloxone, or the naltrexone rather. That in my book means that the patient is highly cooperative and enthusiastic about using the drug and very afraid of the potential side effects. So the sufentanil recommendation comes with the caveat that I will have a conversation with the family, because I have had wives told me, if you give him, patients on naltrexone or naloxone, if you give him an opioid, again, you can keep him because I'm not taking him home. And that's the degree of behaviors that these patients may have. So it has to be a conversation with the family. We are facing this situation. It's an emergency. We need to treat the pain. We'll try ketamine IV, lidocaine IV, all the other drugs. If this is not enough, is it okay to use IV opioids? most of the times the question is no, don't use it. But you know, if they say yes, you know, I will reach out for sulfampicin.
Okay. There's one more question that I think is really extremely important, and I'm going to end with this question. It's what strategies do you recommend to prevent persistent opioid use in opioid-naive patients following surgery? And I'll take a quick stab at that one to say that, you know, there is evidence that Chad Brummett published that says up to in the neighborhood of 10% of patients who have free access to opioids will be using them in 6 months from an opioid naive population. So it is a real concern, and I showed that slide that suggests beyond 5 days you see persistent use. So you know, the best strategies are to minimize or eliminate opioids using all the multimodal tricks in your armamentarium. And it's not so much that you cut patients off, but that you've provided adequate analgesia by other means. There is certainly some evidence, actually pretty good evidence, to suggest that using high doses or excessive doses of opioids during your anesthetic produce worse postoperative pain, tolerance, hyperalgesia, and prolonged opioid use. There's a substantial body of literature that supports that less opioid intraoperatively reduces postoperative pain, opioid use. So I think all of those approaches make sense. There's a question here about using local anesthetics or long-acting local. You know, clearly any way that you can use a regional anesthetic, that's your most potent agent for my use in the surgical setting. So use local anywhere you can. Catheters for extended prolonged local effect. And I think we're about 15 minutes over, so I want to thank.
Let me just say one thing, Gene.
Yes, please.
Yes. So, in your practice, Lynn and Gene, what is the most frequent cause for these patients who show to your clinic with persistent opioid use? And
You know, Oscar, I actually did not hear your question.
okay, then let me stop the questioning and just say it. The most frequent cause for patients that come to my clinic with persistent opioid use after surgery is neuropathic pain.
Oh, okay. Yes.
So the question is, how do you manage them? You know, diagnose them appropriately, see what the source of pain is, and if it is neuropathic, then implement a treatment strategy that is directed towards the management of neuropathic pain, which does not include opioids as the first 3 alternative treatments, but the 4th scale. So diagnosis, I would say, is the most important strategy in these patients.
Yeah, it's an excellent point. You know, we always talk about what's the pain number, you know, the pain intensity, but I think characterizing the nature of pain is probably more important in selecting the correct agents to use. And, you know, when you see that neuropathic signal, those are the patients who are likely going to need follow-up, and otherwise we'll just get lots of opioids. So you're absolutely excellent point, Oscar.
Thank you.
Totally agree.
Okay. Well, thank you for spending some extra time with us, and we appreciate that you are interested in this challenging area. Take care, be well, and we hope to see you on another meeting or a live webinar in the near future. Take care, everyone.
Thank you very much.
Bye.
Bye-bye.